is very warm in these parts.
What happened?
I don't know.
Are we live?
Are we live?
Yes, ma'am, you are live.
Yes, ma'am. Yes, ma'am. You are live.
Thank you. So welcome everyone to this webinar today. And this is a webinar with a difference. Webinar with a difference because we have a very iconic leader, a very iconic presenter, and a ophthalmologist and a surgeon with us today, who's going to be taking this masterclass. And we have none other than Dr. Chitra Ramamurthy, who's sitting on other side of the table today, who is going to be telling us about a very important topic, which we all wonder and which we all have now come to accept, and that is why is cataract surgery poised to be refractive cataract surgery. I would request Professor Rajesh Sinha, who's the treasurer of All India Ophthalmological Society, consultant at Corneal Cataract and Refractive Surgery Services, All India Institute of Medical Sciences, to introduce Dr. Chitra Ramamurthy.
Thank you, and a very good morning to all of you. It's my great pleasure, with great pleasure, and you can't hear me?
Now
we can, sir, we can hear you. Dr. Chitra must be having the audio problem.
Okay.
please tell me whenever it's too unstable.
Ma'am, just wait. Dr. Rajesh, I'll have to call Dr. Chitra.
So with great pleasure, and I consider it as a great privilege to introduce an iconic ophthalmologist, a woman ophthalmologist who has shown the world that how accomplished she is. She is Dr. Chitra Ramamurthy, who is the medical director of the Eye Foundation, a chain of 14 eye hospitals in southern India. She is the chairperson of Academic Research Committee of AIOS. She is also a managing committee member of TNOA. She is highly proficient in cataract, refractive surgery, and glaucoma, a pioneer in refractive surgery, performing refractive procedures since 1997 in large numbers, inclusive of all the cutting-edge technology. Had the special distinction of conducting innumerable instruction courses in both India and abroad, partaking in ASCRS, APAO, APACRS, and ESCRS on a regular basis. Has also many papers to her credit, both nationally and internationally, and has contributed to chapters in textbooks on refractive surgeries. She has held various positions in the past. She has been member scientific committee of AIOS from 2017 to 2020. She has been chairman scientific committee of TNOA from in the year 2002 and 2015. She has received the best paper awards in the states and national levels. And she has also received the Shiv Prasad Hadia Award from AIOS in the year 2009. Dr. D. Sundareshwaran Endowment Oration Award by IMA Coimbatore. Dr. Om Prakash Gold Medal 2016. And she has received many more such awards. And it's a great day today. We are having a wonderful orator and a wonderful speaker with us, Dr. Chitra Ramamurthy. We also have with us as moderator, Professor Namrata Sharma, who is the Honorary General Secretary, a very dynamic lady, Secretary of AIOS, and working as professor in the Cornea Cataract and Refractive Surgery Services at RP Center, AIMS. We also have with us Dr. Naga Harur, who is member ARC AIOS, and she is medical director at Anil Eye Hospital, Mumbai, Maharashtra. So before we actually start, I will just request Dr. Namrata Sharma to say a few words, and then we will begin with the talk of Dr. Chitra Ramamurthy.
So thank you, Rajesh. Fortunately, you are surrounded by three ladies today in the panel, and Dr. Chitra, we have, on trial because she's sitting on the other side of the table, unlike in all the other webinars where she's on this side. So I think without much ado, we would request Dr. Chitra Ramamurthy, the very dynamic chairperson of the Academic and Research Committee, who has shown the world in the last few years of her term how Academic and Research Committee can soar so high, to give her talk, to take her masterclass. on why cataract surgery is now refractive surgery.
Thank you very much. Let me share my screen. Is my screen seen?
Yes.
Yeah. Before I go on to my talk, I truly want to thank Rajesh, Namrata and Rajesh for this wonderful opportunity to partake in this masterclass of AIOS, which was eluding me for some time. And I'm so happy to be doing it today. And as far as all the other things which was said about me, being part of AIOS and being part of GC, there is so much of professionalism and so much of leadership. It just gets rubbed on to all around and everybody ends up doing their best. And of course, with the support of the entire members of AIOS. So without ado, thanking all of you for being here, I shall go on to my talk. Why is cataract surgery poised to be refractive cataract surgery? Now, we are poised at a moment where the surgeon is at his best. He knows what are the rights and the wrongs about doing a good cataract surgery. The IOL technology is constantly competing to get the best out of the moment. We have a whole lot of phaco machines and other accessories which ensure that the fluidics of the whole surgical process is most optimal. So finally, it is a state where it is what's best for your patients is what has to be kept in your mind at all times. And when it means it's all best for the patient, because the patient is already aware that the surgeon can deliver quite well. And with this kind of a background information, if you are able to convert your cataract surgery into a refractive cataract surgery, believe me, you have gone way ahead in your practice, and that's a big advantage for you. So then we need to look at the very essentials. Now, does the patient need a correction of his asphericity? Does the patient have astigmatism and need correction of his toricity? Would he be happy with a multifocal for distance and near? Could you complement him by giving him trifocals? Or would you think that you could do a mix and a match, or a continuous range of vision, or an extended focus of vision? So these are the different variables which you have to have. And so then it seems logical to break up this talk into pearls. So then the very first question which comes up, what is the right time? The right time, believe me, most of us are doing that, and most of us are also realizing it. But I think all of us should realize by the end of this talk that it is about your level of confidence that you're doing a successful phacoemulsification with minimal complications. You are able to get a consistent wound construction, a consistent capsulotomy with a good overlap of the optic. And most importantly, you are targeting emmetropia, and you are fairly confident or pretty confident of your emmetropic outcomes, which is the most important thing. Your post-op refractive outcomes, if you are able to follow it up and you realize that you are consistent, then actually the time is there. But it doesn't help if the surgeon has just bought into it. It has to be an integrated information to the entire staff, because the patient, besides the chair time with you, is sitting outside for a whole lot of time in different investigative areas, because definitely your investigations get more expanded when you are taking your cataract surgery to a different level. And he is anxious, he is nervous, so he would talk to the room sister, he would talk to the floor sister, he would talk to the counselor, he would talk to the reception desk. So what is important is that all of them talk the same language, the same message comes through, and it's also important that you should have ingrained into all of them your level of surgical confidence, because that would come into them when they come across with these patients. So what is your pearl number 2? Then you need to address the workflow. So most importantly, you need to pick your patients very wisely. You need to understand whether the patient is looking for a great distant vision, is happy with glasses, or does he want intermediate vision more? He doesn't mind wearing readers, or is it that he wants the entire range, or what is he very bothered about the crispness of his distant vision? So you need to pick and choose but you need to have had that small amount of chair time. Either you do it or your counselor does it. It's your level of confidence, but you should have definitely removed that high level of concern some of these patients would have about the night vision related issues or those potential visual side effects. But believe me, if you're hitting target emmetropia, and with the present level of IOL technology and with the biometry techniques which have come up, the issues with multifocal lenses are nearly not there. Of course, we need to make your patient cognizant of the fact that there is going to be some neural adaptation along the way. And if the patient has realistic expectations, you have done the right thing. But it doesn't mean that you crowd him with the entire amount of information as the screen shows, because that's not your objective. You need to just explain as to what you are hitting at with your patient and how cognizant he is. So that means that you need to individualize your intraocular lens selection, choose the right patient and not the wrong lens for a very over-demanding patient. In fact, it's not that one size fits all. In fact, what we do in our practice is, even before you use an applanation tonometry or even disturb the tear film in the remotest way, when we do a vision refraction, we know, take the patient on the slit lamp and you know he has a cataract and we know he's already concerned about it. It's better to do a biometry at that point of time when your ocular surface is intact, and then find out whether there's some amount of astigmatism there. And if so, then your whole direction of counseling would veer more towards toricity or a multifocal IOL with toricity, in case you are desirous or the patient is ready to go on to the next level of going in for a premium IOL lenses. So what essentially it means that to be successful, we need to hit the target. We need to address this very important factor, that how close to the target emmetropia you are. So essentially what we realized that with the third generation formula, 78% of our patients were within plus minus 0.5 diopter of expected target emmetropia, but that was fine and acceptable. But with the coming in of the fourth generation and the more recent formulas, what happened was we found that 90% of the patients were within plus minus 0.5 diopter of target emmetropia. And this was actually achievable. And this was also not only normalized, but could be achieved even in unusual and in complex eyes. What is biometry? Actually, it is just a simple arithmetic measurements with assumptions, wherein it is about the corneal power, K, the axial length, the intraocular power, the effective lens position, and the post-op refraction, and how they all are very closely connected and how you deal with them. But today, with the level of expertise we have with the optical biometers and the way we are bang on in your axial length measurements, we are actually challenged with the effective lens position and the assumptions which are needed for the K value. Now, you could be getting a perfect result like this, plano 6.6 N6 for your patient, but it could have also been that there were actually two errors somewhere in the calculation and they canceled out each other. Or it could be that a patient ends up with this and you just did not expect this kind of a result. And this is a refractive surprise. And what could you have done? Instead of you wondering post-operatively, what could you have done? I'm going to tell you what you could do before to ensure that this does not happen. And what is the understanding which occurs when you understand that bit more. So basically, way back in 2008, what was found was that the effective lens position contributed to 35% of the errors, axial length to 27%, the refraction up to 17%, and corneal power up to 10%. But now we know that the axial length is sort of bang on the measure, because with the frequency of the lasers of the optical biometry, we are fairly accurate with our axial length measurements. And with the kind of consistency in the wound architecture and our surgical induced astigmatism, our understanding of centroid values, and the fact that the IOL technologies are way ahead, and the fact that IOL labeling errors are not happening, all these put together, we are again doing pretty well in the refraction area, but we are stuck with the effective lens position because of the assumptions we trickle in, and also in certain assumptions which come in when you're doing your keratometric measurement. So then we need to understand that we need to get to all those key areas wherein we can get your best measurements possible. So then comes pearl number 3, that is, how do we go about our accurate measurements? Now we have whole range of biometers now, each to beat the other. That doesn't mean I can put anyone before the other, but it's just that we have the whole market range. So what is it becomes needed for us to know is, as you move on to the optical biometers, the frequency of the laser beams becomes far more accurate and sharpened. And so your exactitude in measuring the axial length or the fixation or the fovea, all these become so much more accurate compared to a sort of certain assumptions or macular or paramacular variable retinal thickness are not there. In fact, if you look at the difference between an ultrasound to the optical biometers, there is about a difference of 200 micron, but that does not mean that the immersion does not stand where it stands, and it stands at a very favorable point. We just need to be very careful in our measurements. Like, we need to know whether our spikes are all equal. We need to know whether we have fed in the velocity specific to the particular eye in question. We need to know whether those scleral spikes are there, whether it's well aligned onto the optic nerve. We need to know whether we have not pressed too much on the cornea. We need to know whether we have kept the gain just enough so that all our spikes are equal. We need to know whether our standard deviation is less than 0.06. We need to have at least 5 to 6 constant readings. Then we are there with the immersion biometer. We also are challenged with the cornea because we need to constantly understand that it could be a normal cornea, it could be an abnormal cornea, it could be cornea that has been modified surgically. And more important, we have again a range of equipments. We are there with a manual keratometer, and with a good technician, we are right there. We know the amount of K value and the astigmatism and the magnitude of axis, everything. You could be having those optical biometers, which I'm talking about. You could be using a topographer, your tomographer with the Shamefung device. You could have an intraoral biometry, but what is important is you also need to know that each of them are measuring at different points. So there is a small difference which could be there, but you need to look at the reliability of these. Of course, manual keratometry is more on a trained technician skills, but you need to compare your keratometry with 2 odd machines or more to confirm the axis and magnitude are nearly similar, and that helps in minimizing the errors. But when there is an error which is there, then believe me, you need to look at the irregularity of the corneal surface. Sometimes an ocular surface which is irregular, or there is a dry eye status, you might be getting challenging readings, and you need to go and address that before you take your keratometric measurement again. Why the optical biometers and the AIOS Master 700 and the total keratometry gained popularity was, there was this other machines where it was a mathematical derivation of the posterior cornea, and the anterior cornea was being measured. But with this AIOS Master 700, what it does is it measures the anterior corneal curvature and measures the corneal thickness at all the points and creates a curvature of the posterior cornea, and thus measures the posterior corneal astigmatism. So you have the measure of the anterior and the posterior corneal astigmatism with the swept source OCT and the B scan. And then this gets incorporated into the Barrett Universal 2 as Barrett TK, Barrett Toric as Barrett TK Toric, and brings in that level of increased accuracy in your measurements. Now, we also need to keep in mind that the other formulas are all doing well. They already have their mathematical derivation of posterior corneal astigmatism in good number of them. So in that, if you add the TK value, let us beware that you might end up overcorrecting the astigmatism, and that could get in some kind of a residual error. So as I had already alluded to, the AIOS Master does come in with certain advantages of even ability to do a fixation check, and of course the concept of 2 ways methodologies involved in doing the AIOS power calculation. But what is also important is that we measure both eyes of every patient. Now, one eye could be a pseudophakic eye and the other eye phakic eye, but what it helps is it looks into the axial length. It looks into the other white to white. It looks into K values. So it also tells you whether there is a variability. Do you need to redo your measurements? Sometimes it could be that the measurements actually bang on, but the asymmetry is actually because of the asymmetry of the eyes. Then there is another warning therein, which tells you that you probably should advise a patient that there is a possibility of amblyopia in this eye, so that you are forewarned and that keeps you forearmed. So what you also need to understand that if a difference of axial length is more than 0.3, if the K value difference between the two eyes is more than 1 diopter or the IOL power more than 1 diopter, you need to be on guard. You need to go back and look at the quality of the raw data. Now, this was a case of a patient who had 0.5 diopter astigmatism in the right eye and plus 2 diopter in the left eye. And when we evaluated him, which we did, thankfully, we found he had severe dry eyes and pigment epithelial defects. So we had to put him on all the artificial tears and the necessary medications. And with time, he settled. And you can see that in both his eyes, the astigmatism had come to equal levels. Had we not looked into his dry eye status, there would have been a huge difference in the IOL power, which we would have inserted in this eye, and that would have led us to a refractive surprise. And this is what was the advantage. So how do you look at the dry eye? Just when you see the eye on the biometer, those fishtail appearance of those LED spots would tell you, or on the Myers, on the topography, those irregular Myers would tell you, because believe me, the dry eye status is so much there. Actually, it is seen that 60% of our routine cataract patients are actually asymptomatic, but they have the dry eye disease. And actually, 63% of them have a tear breakup time of less than 5 seconds. This is not my study. It's a very popular phaco study. 50% of them have clear corneal staining. So then, if you can do the Shermers, if you could do the fluorescein strip, if you could look at the, understand as a dry eye, if you are able to assess the osmolarity, is it more than 300? If the difference between the two eyes is more than 10, then you look at, do you think it's an inflammatory dry eye? Do you do those MMP9 tests? Would you look at the meibomian gland function or the dysfunction? So it opens up a whole range of evaluating the dry eye disease, because you need to be there, because if the dry eye, there is a tear hyperosmolarity, it has been seen that it can even bring on an IOL power difference of more than 0.5 diopters. And here we are talking about target emmetropia. Here we are talking of making your cataract surgery, refractive cataract surgery. So if you have the dry eye status, if you are cognizant of it before the surgery and you treat these eyes, you are actually preventing yourself the distress of explaining to the patient as to what went wrong with his IOL power calculation. When it comes to the screening by the technicians, yes, there are certain inbuilt signals in the machine itself which tells us whether there's an error coming on, but there are small things like a signal to noise ratio should be more than 2. Now, if it's a dense PSCC, you may go wrong in your measurement of your axial length. You need to look at the standard deviation, like in your optical biometry with your K value, if it is more than 0.2 diopters, if it is more than 0.03 millimeters or 30 microns, then it sort of puts you on guard that there is something going wrong. If the axis difference is more than 3.5 degrees, these are those red flags which tell you that things are not actually going good. So then you need to go back and read your measurements. You need to look at it. So now this was a patient who came for a routine surgery, cataract surgery, and had we not looked at his K value, it's so much flatter in the right eye as against the left. And had we not taken the history that he had got LASIK surgery done 30 years back, then believe me, we would have gone all wrong. But once we looked at the K value, realized it was very much flatter, then we go on to the formula specific to the pre-op for a LASIK patient. And then we go to the LASIK mode, we use the Barrett true K values or whichever which you are going to adopt for yourself. And then you arrive at the right IOL power calculation. So in other words, we need to look at the validation guidelines. If there is an AC depth which is too deep or too shallow, the white to white is difference between the two eyes, the astigmatism is more than you expect it to be, there is a difference in the axial length, you need to be on guard, you need to recheck your measurements. So having said enough and more about accuracy in measurements, let's go to Pearl 4. We also know that one formula does not fit all. Now, what we understand is there has been a growth in our evolution and understanding of the intraocular lens power calculation. We started with the regression formulas, which were essentially an average of the analysis of the post-op refractive results. Then we moved on to the version formula, which was a Gaussian optics formula, which what it did was it started measuring variables, two variables. Initially, it was just K value, and then it went on to anterior chamber depth and the white to white, and more kept adding on. Now, why was this? how close are you to measuring your effective lens position? That is where the lens sits in the eye, or the distance from the anterior cornea to the optical center of the lens. Is that constant? We could have we could go to the artificial intelligence, the Hill RBF, which is a very popular formula for many of them, which is again a statistical model where they have a whole range of eyes which have been analyzed, and an artificial intelligence module is used to analyze as what is normal and what is abnormal and what is out of range. And based on that, what we do come to understand is, as the generations of the formula evolved, the struggle was how close are you in measuring where the lens sits in the capsular bag? Because if the lens is more anteriorly placed, you need a lower power. If the lens is sitting more posteriorly placed, you need a higher IOL power. And this is what the challenge was. Now, these problems do not largely occur in normal eyes. You get away with it. In normal eyes, you are fine with most of the formulas. If the normal K values, you're fine with most of the formulas. The challenge comes in extremes of axial length or extremes of K values. The problem is not too significant in a highly myopic eye, which is a long eye, because you're using a low-powered IOL. So even if you're a little off the effective lens position, there is a less impact on the outcome. What does happen is you tend to overestimate the axial length when you're using different biometers, and that could be a challenge. But the challenge becomes profound when you're operating on a short eye, because you're dealing with high-powered IOLs, and a small shift in the IOL can bring on a huge refractive surprise. And this you do not know, is it because of the shallowness of the anterior chamber, or is it because of the increased thickness of the lens, which is causing the eye to look shallower and which is causing a challenge in your IOL power calculation. In other words, you could have a normal axial length and a normal anterior chamber depth. You could have a short axial length with a normal anterior chamber depth in 6.9% of the cases. You could have, in 1.8% of the cases, you could have a short axial length and a short anterior chamber. You could have an eye with a normal anterior chamber and a long axial length in 13.5% of the cases. You could have 1.5% of the cases where both the anterior chamber depth and the axial length are long. So imagine the huge variations which are there, which is going to be constantly challenging you when you're looking at a short eye. And this is where in the newer generation formulas, which have incorporated more variables in better assessing the effective lens position, get closer to target. And that is where we talk more about the newer generation formulas in extremes of axial length. Now, when we are talking about the toric IOL, we need to understand about this toricity ratio. Now, toricity ratio is just the ratio of the astigmatism of the IOL plane to the astigmatism in the corneal plane. Now, if it is a myopic eye, it's a deep anterior chamber, and if it's a hyperopic eye, it's a shallow anterior chamber. And definitely the toricity ratio is going to be altered. And if you use a standard biometer and the standard anterior toricity ratio of 1.45, you are actually off the mark. What could happen that this patient had a +2 diopter of against the rule astigmatism, but in a normal eye, you need T5, and in a short eye, you need T4, and in a long eye, you need T6 toric IOL series. So imagine with the same magnitude of astigmatism, in different lengths of eye, you need a different kind of toric IOL placement. Again, when you look at the Barrett Universal 2 formula, you understand that these are the 5 major variables besides the lens factor, which is essentially the distance from the iris plane to the posterior principal plane of the IOL. It also has a Barrett suit, wherein it has the Barrett Universal 2, the Barrett Toric, and True K. Now, what it does in Barrett Universal 2, again, it uses a thick lens formula. How it does is it uses these variables to identify where the IOL is going to sit in the eye, including the principal plane of the particular IOL in question. With the Barrett Toric, it looks into the posterior corneal astigmatism. It also looks whether it's with the rule or against the rule. And with the Barrett True K, it uses its own mathematical model and also uses the double K solutions to arrive at what you would do in a post-refractive surgery eye. And then, of course, the Barrett RS formula in cases of refractive surprises, and a Barrett True K Toric, which came in with the total keratometry. When we talk of the principal planes, what we need to understand is that when you are going in for hyope parts, normally you would have used a biconvex IOL, but as you move on to plano-convex or meniscus lenses, because of the shape change of these lenses, the principal plane of the IOLs also drifts, and these also could impact the effective lens position, and thus your IOL power calculation. And this is what the Barrett universal formula has circumvented. You also need to know about the toric calculator. When I'm talking of refractive cataract surgery, we definitely need to assess the astigmatism. So does your calculator account for posterior corneal astigmatism, the toricity ratio, which I alluded, and the centroid values? Like for an example, there are different toric IOL calculators. I've just put this Alcon one here on the screen. It tells you about the keratometric index. It gives you the centroid, takes the centroid values. It does look into the toricity ratio. And you could feed these into the Alcon toric calculator and get your actual toric IOL plan. Now, what is this posterior corneal astigmatism? It's something I'm sure all of us know, that the posterior cornea is steeper in 90% of the cases, and which creates a value of about 0.3 diopters on an average. It creates a minus lens, which creates a net power along the horizontal meridian. Now, largely, if the anterior cornea is with the rule, and if the posterior cornea is against the rule, then your total corneal astigmatism is less, which is so natural. But if both the anterior and posterior cornea are against the rule, that your total corneal astigmatism is more. And let's understand that the posterior corneal astigmatism does not change with age. Now, little on centroid value, what it is that when we talk of surgical induced astigmatism, we are looking into the total astigmatic magnitude of the eye. And traditionally here, and if you look at the above figure, is 0.35. But if you look into the axis, just not the magnitude of astigmatism, and if these axes are on opposite meridians, then the centroid value comes to 0. In fact, it has been seen that for all incisions about 2.4 millimeters, the centroid value is just about 0.12. And for a larger incisions up to 2.8, it comes to about 0.3 to 0.4 astigmatism. Supposing you have an immersion biometer wherein you have taken all the values, the axial length, taken the keratometer from your measurements of K values, you can go into those any online formulae or a Barrett formulae, and then you could feed in these data. Only thing, you need to feed the acoustic factor of the IOL in question and feed that in, and it would tell you what is going to be the axis of your IOL placement and what is going to be your residual astigmatism, and you could still go on. There are certain additional measurements which are needed in unusual eyes. Like this is a flow plan. Like in 70% of the eyes, you ask the patient not to blink, go ahead and do your keratometry. But when your standard deviation is off, more than 0.2 or more than 0.303 millimeters, are you looking at dry eye? And if you are, you evaluate for dry eye, you treat the dry eye, and then you take your measurements, then you're bang on. If it is an eye which has had a refractive surgery, or there is a keratoconus, or there's a PMD, you need to move further. You need to do a topography, a tomography. You could do the EKR measurements largely at the 4.5. But again, if it is a post RKI, you might want to go to a smaller K, even smaller pupil. You might go to a smaller EKR value. And then, of course, you want to know the posterior corneal astigmatism. So you would want to go on to your optical biometers, the latest formula. So you need to go a little off your normal track when you are looking at that 30% of the eyes only, which need those extra measurements before cataract surgery. Then comes Pearl 6. Now, what is your threshold for toric IOL? Now, it can't be just said generally, oh, I would do all toric IOLs above 0.7 diopter astigmatism. No, I would measure my astigmatism and I would feed it into my biometer. And if it tells that 0.97 here, it tells that it's with the rule. You don't need a toric, but it tells that for a 0.88 against the rule, yes, you need a T3 series, and that would be how your decision would change. So what becomes important is you look at the ocular surface, which I've been repeatedly telling, do a thorough refraction, look at the position of your lens. Is it sitting in its normal place? Is it like there is some amount of subluxation there? Is it there a pseudo exfoliation there? And of course, you would like to do an OCT besides all others, eye trace, whatever you want to do, all your measurements, and then go on and even do a thorough retinal evaluation. You would look at the ocular surface. You would look at the fluorescent staining, the tear breakup time. You would look at the meibomian gland function, and all this would direct you towards a probable pathology of treating the dry eye. You would do a specular biomicroscopy. Does the patient have a good endothelial cell count, or is it less than 2000? Is the coefficient of variance, is it more than 40? Is this something suspicious about the sizing of these cells? Then you would decide, would you just tell the patient that you would do a cataract surgery with a lot of viscoelastic protection for the endothelium, or that he might need a DSEC at a later point of time, or would you do a combined procedure? You would ask your cornea consultant to opine on that. You would look at the topography to see whether it's an irregular astigmatism. Is it an irregular astigmatism? Would you actually consider doing a topo-guided regularization of this astigmatism before you go on to placing your toric IOL or any of the premium IOLs in your post-refractive surgery eyes? You need to do an ocular OCT of your macula, whether the macula is really healthy. Are you going to guarantee that N6 vision, or would you be doing a phacoemulsification surgery and also take care of the ERM in the course of the surgery? Because we do have our retina surgeons geared to do all that we need to do. You have an access to eye trace. You would look at the angle alpha, whether it's less than 0.5. You would look at the higher order aberrations. If this was going to impact your going in for putting a premium IOL in your patients, what is the dysfunctional lens index? Is it less than 5? Then could you actually even consider doing a clear lens extraction in some of these early presbyopes or hyperopes? You would want to see whether all the optical center, the pupil center, and the visual axis center are all closely packed together. Then you're pretty extremely superb case for a premium IOL patient. And if today we have these pan-optic symphony synergy, I'm just taking names of some lenses which have a larger central optic zone, which is more forgiving. So even if your angle alpha is 0.5, you could, or even 0.8, you could still go ahead and implant these IOLs and still get the most premium results for these patients. Again, we need to match the technology to the patient. Like you have IOLs of different optical designs, the earlier refractive IOLs with multiple focal lengths, diffractive with a distance and near and a combination, and the focality, whether it's a bifocal lens you're going to advise for a distance and a near vision. Would you want him to give a good intermediate vision without dysphotopsia? Would you want to give him an extended depth of focus lens for him? Would you want to give him a continuous range of vision lenses for him? Would you want to just give him that little intermediate with your eye hands or VVT? Would you want something more? Would you want to do a micro monovision for these eyes? These are some things which you need to know. And if you want to know a little more, essentially what you need to know that these diffractive circles is like how a wavefront hits an object. The diffractive patterns are created, and the zero order goes to distant vision, first order go to near vision. Then it will tell you what is majority of these lenses have 40% distribution for distance and near, but based on apodization, based on the heights of those rings or the widths of those rings, it would further decide how much of light is getting distributed for distance and how much is getting distributed for near. It is not necessary that you need to understand the whole jargon, but some of it our sales guys are going to tell us anyway that what is the advantage of that particular lens, and that you need to be cognizant about. And you need to understand that we have evolved to a point that we can actually give all of it to our patients without an increase in dysphotopsia. But then when you're talking to your patient, you're not going to be talking of modular transfer function, but you need a real world measure of the intraocular lens formula. You need to have the best objective indicator. And that is where you are able to set realistic expectations to your patient. And you need to know about the defocus curve of that particular lens in mind. So what is defocus curve? It's essentially you give the best corrected distance vision correction to the patient, and then you keep adding 0.5 diopters, and you try to see what is the range of vision in these eyes. At 0.1, the patient is able to read what he can read at 1 meter. At 0.4, he's able to read what he could read. At -4, he can read what he could read at 25 centimeters. So basically, it tells what is the range of vision that particular lens is going to give. And based on this, they came in those lenses which had a low ad, which would give you this amount of defocus curve and this range of vision, more better vision for intermediate vision, so that there was less of dysphotopsia claims as compared to giving more close and near vision. So then we need to choose the right IOL for the patient based on what kind of spectacle independence he wants. Does he want a lot of near vision? Would you consider give him a Technis multifocal with a +4 ad? Or he doesn't mind occasional reading readers, then you could think of giving him an EDOF lens. Or he wants a continuous range of vision, you give him a trifocal or a synergy lens. But most importantly, if you have a laser cataract platform, then go ahead. You are actually able to size your X's based on the capsule size. Then you could even plan your arcuate incisions. And then, of course, going forward, you're able to go on to your sections or your quadrants and how you're able to get a free floating Rexes. And you're so sure about your Rexes as if it's repeatable, the same results in all your hundreds of cases. And you sometimes in these early cataracts, all you need to do is just visco dissection and you separate the fragments, or you just keep the machine on your fluidics, adjust the vacuum with aspiration mode and no ultrasound. And there you have all the lens pies coming forward and there's hardly any damage to your cornea. And the manipulations are so minuscule. And there you are implanting the lens. It's barely an edited version. And then you're all about is removing the viscoelastic behind the lens and front of the lens. And there are great guys who do even hydroimplantation of the lens, which even takes them forward. And centering the lens, which is so important. You need to have a nice round Rexes. You need to center your lenses. See, those rings are well centered on the Purkinje reflex. The first and the third Purkinje reflex to coincide. And then you go ahead and open your arcuates. You could even open the arcuates while the eye is firm before you start the surgery. And that's how optimal that you get. So then comes pearl number 10. Now, what is the threshold of using a toric IOL? Believe me, you need to correct the least amount of astigmatism, which you could when you're using a multifocal IOL. Like this was a case who had +1 and 0.8 diopter of astigmatism. And at that time, PanOptics was planned and the PanOptics toric had not come in. So a PanOptics lens was implanted in this eye and the patient was left with a small amount of astigmatism. We reassured him that we do the other eye, waited and went ahead and implanted a PanOptics toric in that eye. And of course, and then a laser vision correction was done for the earlier eye of Biometry. And finally, the patient ended up with a plano 6/6 in both eyes. Believe me, that is how the patients drive us, even if you are not ready to be driven. So, and then when it comes to low diopter of astigmatism, and if you have access to a femtocataract platform, you would go after all these minuscule astigmatism errors, because today you have the ability to measure your keratometry, your pachymetry at different points. You can do your real-time OCT. What is going to stop you from doing your arcuates and just getting right there when you need to with these patients, and then place the arcuates and open up these arcuates at the end of the procedure? Then it's about nailing the target axis. Now, you could actually make the patient sit on the slit lamp and mark the central line between 3 o'clock to 9 o'clock with the patient's eye well aligned. You could use an Asico bubble marker, and you could measure the patient looking straight ahead. You could measure the 3 o'clock, 6 o'clock, and 9 o'clock position. You could not have some of these measurements. You could just measure it on the slit lamp, and then you could go on and place the Mendelssohn's marker on the surgical table to make sure that your 3 o'clock, 9 o'clock are on axis, and use your toric axis marker and mark the axis of placement of the IOL, ensuring that there's not too much ink which is being used. You could also go ahead and have a Varion overlay or a Callisto or whichever digital overlay you have, and you do a good surgery, do a posterior capsular polishing, inject viscoelastic, place your lens, ensure that the haptics gently opened in the bag, remove the viscoelastic, and finally lock the IOL into its final position where it is to be aligned and check it is bang on, and the surgery is done. But what happens if your IOL is not well aligned? And it's actually, we keep our patients patched for an hour after surgery, because a good majority of the eyes are known to rotate within the first hour. And then we call our patients after the second week, by the second week. And if at that point of time, the axis is off, you can take him on a slit lamp, determine the current alignment of the IOL, and rotate it to where it should have been on the marks of the IOL, measure the beam, enter the manifest refraction, enter what is the current location of the toric IOL, and you could do it on astigmaticfix.com, and it would tell you what should be your new ideal axis of placement. But what is most important here, you need to look at the refraction. If the spherical equivalent is near zero, then it makes sense to rotate your IOL. But if it is not so, then it could actually mean that the problem is there in the IOL itself. their rotation is not going to help, then you might have to do a bioptics for these eyes, or in an extreme situation, you might have to exchange the toric IOL. But in this particular case, the patient did well, and you could use even the Barrett RX formula, which does an outcome analysis, which tells you whether rotation will help for this patient, or using a piggyback lens would help for this patient, or would you actually have to do an IOL exchange for this patient. Now, how long would you wait before you go back to realign? Maybe you could wait for up to 2 weeks before you go back to realign. You need just that little bit of capsular fibrosis, and then you could go back and reposition the toric IOL if it is not aligned. So Pearl 14. So it is important that you follow up and follow through. And believe me, there were 2 important studies, the Concerto study and the Harmony study, which showed that 94% of our patients with the modern premium IOLs would suggest these lenses to their friends and family. So friends, we are not where I am taking you. We are there. We are poised to have all our cataract surgery patients being treated as a refractive cataract surgery patients. And unhappy patients, believe me, today are a rare phenomenon. It could have been a surgical complication. It could be rarely those eyes which had a little poor uncorrected vision, either for distance or near, or you need to identify, is it a temporary poor quality of vision? Was it a dry eye issue which needs to be addressed? Is it a binocular vision problem? Let's understand, we are not going to get defensive. We have done all our homework, but still things could not be so ideal with your patients. We cannot be dismissive. If you're along with the patient actually doesn't mind if he's left with a small residual error. But yes, you need to go slow on these eyes. You need not do a bilateral cataract surgery in these particular eyes. At least I am more conservative. I may stand to be corrected. But then if the one eye, the distance is doing well and the intermediate near is not too good, you could do a micro monovision, or you could do a mix and match, which I would address as I go on. You need to understand first, is it the lack of clarity, a visual disturbance, or a glare, or a halo, a starburst, or is it a lack of clarity specific to a viewing distance, a distance or near, or is it something which is not there initially but happened over a few months' time? So then this is when you could think of a blended vision. Now, in this particular case, this was a patient who had a Symphony multifocal IOL, great vision for distance and intermediate, but not so happy for near, and he wanted to read more. So we went ahead and suggested and implanted a Technis +4 in the other eye, and the patient was extremely happy and was doing well. This is another example of a mix and match, wherein the patient had underwent a Symphony in one eye, great vision for distance and intermediate, but needed a small correction for near. What you could do is you could still implant a Symphony, and this, of course, this patient needed a Symphony Toric too, and you could target a little myopia in the other eye, and then you could go ahead and end up with a most appropriately happy patient. When you look at these unhappy eyes, you need to look at the different C's. Is there something on the cornea which should have been addressed? Was there a corneal irregular astigmatism which you missed? Is it because of the dry eye status? Is there a small amount of cylinder or residual refractive error? Would you need to look at the topography, the pachymetry thickness? Could you suggest a bioptics for these eyes to take care of the issue? Is it that does it really actually need an IOL exchange? Are there capsular opacities? Even if the capsular opacity, need to rule out all other possibilities before you jump to remove the do a YAG capsulotomy, because for all you know, that patient might be intended for an IOL exchange. You need to look at the macula, whether there's a CME or some other macular problem. And most importantly, you need to look at the centration of the IOL. So essentially, post-operatively, the lesser the medications you give the patient and keep the patient with an added artificial tear substitute. I actually keep my patients for even 3 months, especially the women folk, for as long as they're totally comfortable when they are off their post-op medications. We need to be cognizant of what is this disc photopsia. It's essentially a signal to noise ratio. Basically, the multifocal IOLs work on a principle of simultaneous vision, where one image is in focus, the other out of focus image gets suppressed, and it is this out of focus image which gives this phalos. We also need to remember that human eyes are not prepared physiologically for a multifocality of vision. So all these IOLs are so designed that they try to ensure that there's a maximal physiological division of light for distance and near to give as good a multifocality as possible. But then with the advancement of IOL technology, the square edge, which seemed to be great for the PCO, and the high refractive index lenses itself is causing positive dysphotopsia. But we need to, that is where you need to have told your patient about the neural adaptation, which does happen within 3 months or rarely up to 1 year. Neural adaptation is even better with the younger patients. And if they are cognizant of that, they are quite acceptable. But then we can't just sit back and think it's just positive dysphotopsia. We need to rule out the refractive error and an ocular surface disease. You need to be sure that your IOL is well centered in the capsular bag. Is there a PCO which could be contributing, or whether you need to treat, or whether the patient, you've tried it all, you feel the IOL exchange is the only solution to your unhappy patient, then it is not too difficult. You could go ahead and do it. Negative dysphotopsia, again, it is that temporal shadow which a person sees. It is again related to the IOL material, the refractive index, and the truncated edge. It also could be because of the relation of those kind of bang-on centered rexes which you create, and the edge, capsulotomy edge margin, and the IOL, and the diffraction of light, and the Lambertian scatter which happens. But believe me, although negative dysphotopsia is seen in 15% of the eyes to remain, majority of them resolve with reassurance. But the ways out of it is you could place a plano part piggyback IOL in the sulcus, or you could do a reverse optic capture. Rarely you might have to do a nasal capsulectomy, or very rarely you may have to do an IOL exchange. And when it comes to cylindrical residuals or any residual refractive error, you could look at bioptics, a piggyback IOL, or a lens exchange. And in capsular opacities, we really need to be very sure you have ruled out everything before you plan to do your YAG capsulotomy. And I would advise that you ask your retina guide to look at, and if there is PVD, then you are even more safer in doing a YAG capsulotomy, and definitely not before 3 months. And you should be sure that IOL exchange is not on the agenda. We need to look at the retina, whether VMT or lamellar hole, or a CME, which has to be treated, a DME, which has to be treated, an ERM. We need to look whether IOL is well centered, go back and recenter it. Rarely it could be an IOL patient who has come from elsewhere and a haptic is broken and you realize it on the surgical table. Rarely you would be a capsular bag, which is actually, there is a zonular compromise there because of which your IOL is not centered. Is it an asymmetric bag contracture because your rexus was not well centered? Was it a large angle alpha? Was it a hyperopic patient? And this was a patient who did come, which showed clearly that his spherical equivalent was nearly 0. He needed an IOL rotation. But when we went in, we realized that there was a small dialysis, and we went ahead and placed a CTR in this particular patient, and we did well. Finally, it could be a good surgery and a wrong patient. Let's understand, we do not have IOLs of every minuscule sizes, and we need to tell our patient that laser vision correction is also there as a part of your plan in your refractive cataract surgery. And my final pearl 15, is top concern. Let's understand, all this while when I was talking to you about refractive cataract surgery, do not go away thinking that I'm going to be fixing a multifocal or a toric IOL in all my patients. My doors are open for the poorest of poor patient, the middle patient. I would do my best with all that I said to give him the best distant vision, the best possible, because the IOL manufacturers have given us a range of lenses to play around with, that I would choose what is best for the patient. So it becomes important that we educate ourselves and we educate our patients, and we are not selling our technology. What I would like to conclude stating that the whole thing, why cataract surgery is poised to be a refractive cataract surgery today, is because we are there. But we need to have a conceptualized approach in our mind. We need to keep our mind open to all possible challenges, and we need to choose the right path to what extent we can get, and then we are just there where you want to be. Thank you very much for this listening. Thank you.
Thank you, Chitra. I think that was an excellent and very complete and comprehensive, talk on why cataract surgery should be refractive surgery. And I think you covered even the smallest of the point about everything. And I think it's a very difficult topic because it's a topic which comes out of experience, which you have so much. and such finer points and fine points. You will never get it, this kind of a talk, you'll never get it in a textbook or in a review article or anywhere. It just comes out of experience. So that is why it is so valuable. We had a huge amount of people who were watching on the Facebook and on the YouTube. I think Dr. Anand is going to give you the stats, which has been quite good. And Anaga, would you like to give any comments and ask questions?
I'm actually truly scared at this point of time because I have been moderating all these webinars, and I hope Anaga doesn't punish me.
Ma'am, first of all, I would like to congratulate you for such a wonderful talk. Actually, it is like a textbook only that you have actually demonstrated, and with all those examples relevant for every point. I think it is for every postgraduate as well as every practicing clinician. I think this is going to be a nice thing to fall back on and go back and check whatever they want to have. It's absolutely fantastic, and thank you so much for thank you, Namrata ma'am, for making me a part of this. Ma'am, if I could just ask one doubt. Like, for example, like we have these very dense, hard brown cataracts where the posterior segment is also not visible. The patient is demanding and he has, for example, a one diopter against the rule astigmatism. He wants a toric multifocal IOL.
Yeah.
So in these cases, like, there may be zonular weakness, and on table you could have rents, and so patient is poised for a toric multifocal. So how would you go ahead, and what would be your plan of action? This is for the benefit of viewers.
If it is a dense hard cataract, I would come out totally into the open to the patient and tell him without frightening him off that there are these challenges, and I would do all that is possible, but this decision might alter on the surgical table because these eyes, your capsule is very weak and there are going to be challenges. But again, the actual challenge would also be, if you have not seen the fundus, it's very important to do a B scan biometry for these eyes. I mean, B scan has to be done. And sometimes you might find that the best of optical biometers may not actually get your measurements right. And that's when your immersion biometer also comes to aid. So we need to have those values also in mind. And go ahead and do a surgery based on your surgical proficiency. Go ahead and take up these cataracts. And honestly, if you're on the femto cataract platform, that sort of takes away half of the stress because the manipulations in the course of the surgery itself becomes so less challenging. And then if there is a very minimal bag compromise, worst case scenario, you could just put in a CTR also and place your toric IOL or a premium IOL in these cases, because there would have been a lot of pressure on the part of the patient and you wouldn't want to miss out anything in these eyes. But then you could have a refractive surprise too if your IOL calculations have not been very optimal. But you are able to bail yourself in good majority of these eyes too.
Yeah, thank you, ma'am. And I think one point is communication with the patient and the relatives at any point of time, pre-operatively. I mean, more chair time pre-operatively and post-operatively. Today, in today's world, especially where medico-legally patients are at the drop of a hat, they may, come back and doubt our skill or the outcome in case there has been a not so optimal outcome. I think that communication would be probably very, very important. Yeah, thank you so much.
Chitra, there are a few questions which have come on the YouTube, and one is that if it's a sports person or an athlete person, then what kind of a lens would you want, EDOF or a trifocal?
I think by personal experience, trifocal patients are very extremely happy, but you could do those continuous range of vision like the synergy which you have, and definitely it comes of great help. Actually, when it comes to synergy, they say that you make these eyes very minimally hyperopic so that the dysphotoptic symptoms are even lesser for these eyes. So I would look at the continuous range of vision or the trifocals for these patients.
Then there's another question by Professor Nazrul Islam from Bangladesh, and he wants to know that in cases of primary open angle glaucoma, and you happen to be a glaucoma specialist as well, which if the patient wants an IOL and he wants a presbyopia correcting IOL, which lens would you prefer?
Yeah, now that is a fair amount of a challenge. Of course, I would invariably convince my patient to go in for a great monofocal lens in these eyes, because you don't want even a minuscule compromise in the contrast sensitivity, which is already hit for these glaucoma eyes. Because in the multifocal lenses, there is about 20% or 14% of light loss does happen. But having said that, I have implanted multifocal lenses in these eyes by literally frightening them that they may not get the optimum results, and they do get optimal results. Because I have started feeling it has a lot to do with the biometry, which is so accurate for us that we are able to wear and go on to do presbyopia correcting IOLs in also those gray areas which we would never step to earlier in our career.
Okay. So I think we've answered. I'll just ask you one question, which I think you have also asked in your webinars. And I think we just want to reinforce that. Suppose a patient is not able to afford and has astigmatism, say about 1.5 diopters.
Yeah.
So would you go in for a Toric IOL, which is of Indian origin, vis-a-vis some other IOL which is imported?
Yeah. No, honestly, although I have a great respect for the imported IOLs, for the simple reason that they have had ways of assessing the chromatic aberration, the spherical aberrations, and the light distribution, and so many analysis of the results have happened, as against which we need to do for our Indian IOL manufacturers actually. But the multifocal IOLs of the indigenous ones of the Indian origin and the Toric IOLs are doing very well. So maybe I would personally prefer to put an hydrophobic platform for these patients, but these patients do equally well or very significantly well. And the credit again goes to how we are looking into all the other aspects, the ocular surface, the biometry, and all that which I alluded to, which all is done properly. Then you could very easily, many patients would do an LRCS and they don't want to spend that much more for the imported. I put a Indian multifocal in these eyes and they are absolutely happy patients.
Then there's another question that sometimes optical biometer shows astigmatism while keratometry on the AR doesn't. So what would be your, how do you go ahead with it?
Yeah, I would definitely go and do a topography. It might be a drier issue, good majority of the cases, and we would like to tally it. If whenever there is a difference in measurements, you would like to look into 2-3 modalities to be really sure whether everything is all right, and then go ahead and implant your lens.
And I think this question comes up always, nearly always, and the question is that which IOL would you prefer in a ophthalmologist who's young, active, young in the sense who's still active and is operating?
Oh, yes. Like if it comes to me, I would actually love to go on a femtocataract platform and go for a multifocal IOL, a trifocal, and a synergy. And I don't know. I mean, I do not see the kind of happiness and the glow which I see on these eyes. I would any day love to throw off my presbyopia correction and go on with these lenses. And I'm sure I love to operate till I drop dead. So.
Okay. So thank you so much.
Anaga doesn't agree with me on that? Unmute.
Of course. Yes, of course.
Amrita? Not sure.
No, I am sure. As of now, I would, if I have to, do it, I'll still go for monofocal and not multifocal.
Oh, okay. Rajesh, you were not there, so you could tell us.
No, actually,
Rajesh, if you were to operate on an ophthalmologist, Rajesh is going to answer that very diplomatically. If you have to operate on an ophthalmologist who is active and who's still operating, what would be your choice of intraocular lens?
see, it's very easy to operate an ophthalmologist because he will understand the pros and cons of every lens. So after discussing with him, I can go ahead with what Dr. Chitra has told. We can go ahead with any monofocal or a multifocal lens or whatever. Because the patient himself is understanding. He can himself guide me to put the kind of lens that he wants.
Okay, let me put it the other way around. So Chitra will have multifocal if she has a cataract, Anaga, what would you have in your eye if you have a cataract?
Enough, ma'am.
As of now, Adolf. And
Enough.
Raj, what would you have if you were to get operated as of now?
Who's Rajesh? My God, so
Okay.
thoughtful.
See,
Yeah.
I would first ask Dr. Namrata because although she doesn't look like, but she is older to me, so she will have, hopefully she will have cataract before me. So
Yeah,
first, I would like to have her answer and then I will answer.
And then answer. So, if I may say so, I'm sure the experience of contact lenses is different from the experience of intraocular lenses. But I do realize that when you switch on and off your contact lenses for a monovision, when you're in that presbyopic age group, or otherwise, when you go for multifocal contact lenses, I'm never happy with that kind of a option. So I want a best corrected distance vision and a best corrected near vision, or intermediate vision without any compromise. So I perhaps whatever range is available now will not go for multifocal lenses.
No, after my talk, I thought you would think a little. I wear multifocal contact lenses and I do so well with it. You get great vision. That is how technology stands today. But she's still way off getting a cataract. So probably she can still play around now. But don't lose out on those premium patients.
So Rajesh, what is your answer now?
Okay, my answer will be this, that hopefully by the time I will get cataract surgery done, there'll be, all these lenses will become outdated.
And you all would have tried these
There'll
lenses
be a fresh
already.
set of lenses that will come, which will have much better. Actually, these days, the question is not about distance vision of 6/6 and near and 6 or intermediate. The bigger issue now is of the photic phenomenon. And hopefully, maybe in another 10 years or 15 years time, when I'll have cataract, then there will be a separate set of lenses which will have less photic phenomenon. And in such a scenario, a more flexible lens, if it's available, I may go ahead with a sort of accommodative kind of a thing.
So we'll have to, somebody has to discover. So both me and Chitra will tell you, Anaka and Rajesh, what to go for after we've experienced
our respective experience.
Yeah. There is one question from one of the panelists who is available physically somewhere. So he's wanting to know that if you have to undergo a cataract surgery, would you like to undergo a flax or you would like to undergo a conventional phacoemulsification?
No, if the patient is willing for a flax, I wish flax could be.
No, I'm talking about now. The question is towards each one of us. Like if we have to undergo a surgery, cataract surgery.
For myself, I told already I would go for a flax.
Flax.
Huh?
Flax.
Yes.
Okay.
Flax, yes.
Flax for the very reason that you will have a very centered and absolutely perfectly sized capsular axis.
And so absolutely the minimal manipulation in my eye.
Better, effective lens position.
Yes.
For safety.
So this one, Rajesh, you will have to answer first, then I will answer.
Yes, I mean, seeing the outcome that, so far that I have done, I won't hesitate in undergoing a flax surgery.
Yeah. That's again a guarded statement. I wouldn't hesitate in undergoing.
No, I mean, I will prefer to undergo a flax.
Okay. So I think for myself, it really actually doesn't matter. I know both ways work well. I think I would this thing more on the surgeon than on the technology. That will be a more difficult, more easy choice.
Now you are doing the same thing.
Amrita is totally being diplomatic.
Learning
the same thing what I was doing for the previous question.
Previous question. So,
okay, so I think we've had a great talk and a great discussion. And Chitra, it was just superb. It will go into the archives, and I'm sure it is going to be useful for everybody because of the numbers that have watched today. So thank you very much for doing it, Chitra, and for bringing out so many things. Thank you, Anaga, for being there. And of course, my co-moderator, Dr. Rajesh Sinha, who's always there. I would like to thank Mr. Sharik and Dr. Anand Sethi's team for doing this. And we'll come back with another masterclass, but I'm sure this is one of the best masterclasses that we've ever had. So thank you, Chitra. Thanks.
Picture, ma'am.
Thank you. Thank you so much, Namrata and Rajesh and Anaga. Thank you so very much.
Yes,
What's
ma'am.
that?
Taking a picture, ma'am.
Picture. Yeah, send it. Yeah, with all of us.
Thank you.
Thank you so much, ma'am. Thank you.
Thank you. Thanks a lot. Thank you.
Congratulations once
Bye.
again.